Welcome to this deep dive. Today we are looking at something you've probably felt intuitively since you were a kid. I mean, your heartbeat.
Yeah, the heartbeat. It's really the ultimate biological rhythm, right?
Exactly. Usually there is this expectation of just, well, absolute metronomic precision. You put two fingers to your wrist, you feel that pulse, and it's this steady, reassuring drum beat. Boom, boom, boom.
Right. And under normal conditions, it's completely predictable. It adapts perfectly, whether you're asleep or, running a marathon.
But what happens when that metronome breaks? That's the question we're exploring for you today. You encounter the clinical hallmark of one of the most critical and honestly most common cardiovascular conditions out there.
Yes, and suddenly you feel what doctors call an irregularly irregular pulse.
Right. Irregularly irregular, meaning there's just no pattern whatsoever. It's pure electrical chaos happening right in the chest.
And that specific brand of chaos is atrial fibrillation, which most people just know as AFib.
So our mission today is to completely decode AFib for you. We're going to build a masterclass level understanding of this condition. I mean, starting from the literal cellular rebellion happening inside the heart muscle, all the way to those split-second life-saving decisions that emergency room doctors have to make.
It's a huge topic.
It really is. We're going to explore the overarching clinical strategy called AF care, which stands for managing rate, rhythm, and anticoagulation. And just to set the stage here, the remarkably detailed source material guiding our deep dive today was provided by Dr. Asifullah KMU Imes Kohat.
Yeah, that material provides a really fantastic foundation because, AFib is never just a single isolated problem. It's a cascading failure of the heart's mechanics, its electrical wiring, and ultimately its physical structure.
Yeah, so to really understand how a heart fails, I feel like we need to go down to the engine room, right? We need to look at how it's actually supposed to work.
That makes sense.
So in a healthy heart, you have what's called normal sinus rhythm. Can you walk us through that baseline?
Sure. So at the very top of the heart, in the right upper chamber, you have the sinoatrial node, or SA node.
Okay.
Think of it as the heart's natural master pacemaker. It fires this clean electrical signal that spreads evenly across the top two chambers, the atria, and this causes them to squeeze in a beautifully synchronized way.
And that squeeze delivers something the sources call the atrial kick, right? What does that actually do for our blood flow?
It's crucial for efficiency.
Yeah.
So gravity and pressure differences naturally pull most of the blood down into the main pumping chambers, the ventricles.
Right, the lower chamber.
Exactly. But that final coordinated contraction of the atria, that atrial kick it, forces the last, say, 20 to 30% of blood volume down into the ventricles right before they pump it out to the rest of your body.
Oh, wow. So it's just topping off the tank.
Yeah, it basically guarantees the heart is completely full and primed for maximum output.
So in a patient with AFib, that beautiful synchronization is just gone. Instead of one smooth wave starting at the SA node, the heart gets overwhelmed by disorganized signals. I mean, we're talking mind-boggling speeds, sometimes 100 to 175 beats per minute.
It's incredibly fast.
Yeah, and the atria lose that kick. They aren't squeezing anymore, they're just quivering like a bag of worms. Why does the machinery glitch that badly?
The underlying cellular physiology is fascinating, honestly. Our sources highlight two primary theories driving this chaos. The first is called the automatic focus theory.
Automatic focus, okay.
Yeah, this involves these highly specialized muscle cells that sleeve the pulmonary veins. Those are the blood vessels bringing oxygenated blood from the lungs back into the left side of the heart.
Right. So what makes those specific cells so dangerous?
Well, they have unique electrical properties. When they undergo stress, whether from high blood pressure, sleep apnea, things like that, they can act as an ectopic focus.
Meaning they go rogue.
Exactly. They basically go rogue. Instead of waiting for the master pacemaker signal, they just start rapid firing their own erratic electrical impulses, completely hijacking the heart's rhythm.
So for you listening, if a normal heart rhythm is like a perfectly synchronized rowing team gliding across a lake following the coxswain's orders, the automatic focus is like a single rogue rower in the back of the boat who suddenly starts paddling at triple speed,
Yes.
throwing the entire boat into disarray.
That paints the picture perfectly. But the chaos compounds, which brings us to the second mechanism, and that's the multiple wavelet theory.
What's happening there?
This occurs when the physical tissue of the heart itself becomes stressed, stretched, or inflamed over time. The heart tries to heal this stress by laying down connective tissue.
Like scar tissue.
Yeah, exactly. It results in fibrosis or microscarring all throughout the tissue.
And I imagine scar tissue doesn't conduct electricity the same way healthy, wet muscle does.
No, it doesn't at all. Connective tissue acts almost like an insulator. So when an electrical signal hits this patchy, scarred tissue, it doesn't pass through cleanly. The electrical wave actually fractures.
Oh, wow.
Yeah, it breaks into multiple random, reentrant daughter wavelets that just loop back on themselves. The signal is essentially trapped, bouncing around a maze of scarred tissue.
Keeping with our rowing analogy, that is like taking the coxswain's megaphone, the single clear instruction, and bouncing it off a cracked mirror, shattering that one command into a million chaotic directions. The crew has absolutely no idea what to do.
That's a great way to put it. You combine those two mechanisms, rogue pacemakers firing rapidly from the pulmonary veins and broken scarred tissues shattering those signals into a million pieces, and you have a heart physically trapped in fibrillation.
But if the heart is physically changing and scarring, how do we get to that point? I mean, a heart doesn't just wake up one day entirely covered in microscars. It must be a progression, right?
It's deeply progressive. Clinicians look at it in phases based on a concept called structural remodeling.
Okay, structural remodeling.
Right. In the early stages, which we call paroxysmal AFib, the episodes are spontaneous. They usually last less than 7 days. A patient might go into AFib, but the heart tissue is still relatively healthy, so within a few days, it snaps back into a normal rhythm on its own.
But I'm guessing if those spontaneous episodes keep happening, the heart eventually takes real damage.
Exactly. When the heart beats erratically for extended periods, the cells become overloaded with calcium. And inside a muscle cell, excess calcium is toxic.
Wait, really? Calcium is toxic to the heart?
Well, excess intracellular calcium is. It activates enzymes that actually trigger more of that fibrosis we talked about. So the heart begins to physically reshape itself. The left atrium dilates, which means it stretches out. And once that structural damage is significant, the heart loses the ability to self-terminate the erratic rhythm.
And that structural damage leads us into the persistent phases, right? Where the AFib lasts longer than 7 days or even longer than a year for long-standing persistent, and it doesn't stop without medical intervention. The sources ultimately label the final stage as permanent. But I have a question about that label. Is permanent a biological point of no return? Meaning, is the heart tissue so destroyed that it's physically impossible to ever beat normally again?
That's a really common misconception. The distinction is vital for anyone trying to understand cardiovascular care. Permanent AFib is rarely a purely physiological absolute.
Oh, really?
Yeah, it's actually a clinical decision. It's an agreement made between the patient and the doctor.
I see.
After repeated failed attempts to shock the heart back to normal, or if the rhythm-controlling drugs cause too many severe side effects, the medical team decides the risks of continuing to fight the AFib outweigh the benefits.
So you just surrender to the rhythm.
Exactly. You accept the chaos and shift your entire focus to just keeping the heart rate manageable and preventing complications.
That's a massive paradigm shift. It's not necessarily that the heart cannot be fixed. It's that the cure has become more dangerous than managing the disease.
Precise.
So if the heart is structurally remodeling over time, what actually lights that fire in the first place? What are the specific triggers?
The anatomical triggers generally fall into 3 categories. The first is cardiac triggers, which involve direct physical stress or stretching of the left atrium.
Like what kind of stress?
Well, for instance, if a patient has mitral stenosis, which is a stiffening of the valve between the left atrium and ventricle blood backs up.
Right, like a blocked pipe.
Yeah, and that increases pressure and massively stretches the atrial wall, damaging the tissue. Congestive heart failure or a heart attack can also cause this kind of direct structural damage.
But the heart doesn't exist in a vacuum, so there have to be outside influences too.
Oh, definitely. Those are the non-cardiac triggers. They're often driven by the lungs or the sympathetic nervous system. So severe pulmonary issues like COPD or infections like pneumonia, they drop the oxygen levels in the blood, which stresses those highly sensitive pulmonary vein cells.
And what about the sympathetic nervous system?
Huge surges of adrenaline from extreme physical trauma, sepsis, or even stimulant use like methamphetamines. That can literally whip the heart into a frenzy.
Wow. And then there are metabolic triggers, which include something I think a lot of people might have actually heard of, holiday heart syndrome.
Ah, yes, holiday heart.
You go to a party, binge drink alcohol over a holiday weekend, and the combination of a sympathetic nervous system spike and severe dehydration causes these massive electrolyte shifts. And it kicks a totally healthy heart right into AFib.
Yeah, it happens way more often than you'd think. ER doctors see it all the time after major holidays.
That's crazy. Okay, so we know the mechanics of the chaos, the timeline of scarring, and the triggers. You'd assume that if your heart was quivering at 170 beats per minute, you would feel like a literal drum solo was happening in your chest. How does this actually look when a patient walks into a clinic?
Well, the presentation is an incredibly wide spectrum. On one end, patients experience terrifying classic symptoms.
Which are what, exactly?
Yeah, they feel severe palpitations, dyspnea, which is profound shortness of breath-crushing fatigue, and sometimes even chest pain.
Right. And if a doctor examines them, they find that irregular pulse. And I saw a specific term in the sources, the apical radial pulse deficit. What does that mean?
It's a fascinating physical sign. So the doctor listens to the actual heartbeat through a stethoscope on the chest. That's the apical pulse.
Hi.
While simultaneously feeling the pulse at the patient's wrist, the radial pulse. Now, because the AFib heart is beating so erratically and inefficiently, some of those heartbeats just don't push enough blood to generate a physical pulse wave that actually reaches all the way to the wrist.
Wow.
Yeah. So the heart might be beating, say, 140 times a minute in the chest, but you only feel 100 beats at the wrist.
That is wild. But what about the other end of the spectrum? You mentioned a wide spectrum.
The silent end. Some patients are entirely asymptomatic. They feel completely normal.
Wait, really?
Yes. The AFib is only discovered by accident when they get an ECG and electrocardiogram for a routine checkup or maybe prepping for a different surgery.
See, I have to push back on this. If a patient feels totally fine, right, and their body seems to have adapted to this irregular rhythm, why do we put them through this massive diagnostic gauntlet? The sources talk about the AF iInvest workup, doing echocardiograms, thyroid tests. Why hunt for the underlying cause if they have absolutely no complaints?
Because the quivering heart is hiding a silent, deadly threat. We don't treat asymptomatic AFib just to make an ECG look pretty. An asymptomatic quivering atrium is just as capable of forming a fatal blood clot as a highly symptomatic one.
Wow. And this brings us right to the crisis cascade. The sources outline 2 massive, life-threatening complications that every patient and doctor must guard against. First, thromboembolism, which means blood clots. And second, hemodynamic collapse.
Let's start with the clots.
Yeah, how does a quivering heart actually create them?
Well, because the atria are fibrillating rather than executing a strong, coordinated squeeze, they basically fail to empty all their blood into the ventricles, and blood is meant to keep moving. When it sits still, it coagulates.
Right.
And there's a specific anatomical pouch attached to the left atrium called the left atrial appendage, or LAA.
Right, the LAA. I try to visualize the main chamber of the heart like a fast-flowing river, and the left atrial appendage is like this stagnant, dead-end backwater pool branching off the side of that river.
That's a great visual.
Yeah, and because the water in that little cove isn't moving, debris, or in this case, coagulating blood, is allowed to gather completely untouched. It just slowly builds into a clot until a sudden current flushes it out of the cove and downstream into the main river.
And when that clot flushes downstream into the systemic arterial circulation, it acts like a missile. Depending on which blood vessel it travels down, it hits different targets. The hit list is terrifying.
Where does it go?
If it travels up the carotid arteries to the brain, it causes a massive ischemic stroke, cutting off oxygen to the brain tissue.
Which is the most common fear, obviously.
Yes. But it can also go to the gut, blocking the mesenteric arteries. That causes acute mesenteric ischemia, where the intestines essentially start dying from lack of blood flow. It presents as sudden, excruciating abdominal pain.
Oh, that sounds horrible.
Or it can travel down into the legs, causing acute limb ischemia, which puts the patient at severe risk of amputation.
Okay, so that is the thromboembolic threat, just a ticking time bomb. But the second major threat is hemodynamic collapse, specifically triggered by something called rapid ventricular rate, or RVR.
Right, RVR.
When the atria are firing at up to 175 chaotic beats per minute, the lower chambers, the ventricles, often try to keep up with that frantic pace. But why is a fast heart rate so dangerous here? Don't athletes have really fast heart rates when they exercise?
They do, but an athlete's heart is beating efficiently. In AFib, when the resting heart rate spikes dangerously high, the ventricles have absolutely no time to rest. That resting phase is called diastole, and it's the brief moment when the ventricles actually fill with blood before the next pump. If the heart is racing at 160 beats per minute, diastole is cut so incredibly short that the ventricles are pumping almost empty.
Right, so your stroke volume, the amount of blood actually ejected per beat, just plummets.
Exactly.
So blood isn't moving forward efficiently. And in a closed plumbing system, if fluid isn't moving forward, it has to back up.
Yes, it backs up from the left side of the heart into the pulmonary veins, and eventually it backs up so far it reaches the tiny fragile vessels in the lungs. The pressure forces fluid directly into the air sacs, the alveoli.
Meaning the patient is effectively drowning in their own fluid.
Precisely. You get rapid onset pulmonary edema, profound shortness of breath, and potentially cardiogenic shock, where the organs just start failing from lack of oxygenated blood. It's summarized by the abstract mnemonic in the literature.
With this massive threat matrix hanging over a patient, let's move into the ER. Imagine a patient crashes through the emergency room doors in AFib. How do doctors even make sense of the chaos?
They rely on a master algorithm for acute triage. And the absolute root question at the very top of that decision tree is simple. Is the patient hemodynamically unstable?
And how do they define unstable in that critical moment?
They look for extreme warning signs using the SHOCK criteria. Syncope, meaning has the patient fainted. Hypotension, is their blood pressure crashing? Are they having ongoing ischemic chest pain indicating a heart attack?
Or the fluid in the lungs, right?
Right, congestive pulmonary edema. Or altered mental status because their brain isn't getting enough blood.
So if the answer is yes to any of those, the patient is unstable. And the clinical action is immediate. It's synchronized direct current cardioversion. You shock their heart with electricity to instantly reset the rhythm.
That's right.
But hold on. Earlier, we talked about how dangerous that stagnant backwater pool in the left atrium is, the LAA. We know blood clots hide in there. If an unstable patient comes in and we immediately blast their heart with electricity to force a massive healthy squeeze, aren't we risking violently dislodging a clot right into their brain?
It's a huge concern.
So shouldn't we give them blood thinners and wait?
It's a completely logical fear, but the medical directives are crystal clear on this. Do not delay for anticoagulation if the patient is actively crashing.
Really?
Yes. If a patient has no blood pressure and their lungs are actively filling with fluid, they will die in the next few minutes. You have to save their life in that exact moment. You accept the risk of stroke to prevent immediate cardiovascular collapse. It's life over limb.
Understood. Okay. But what if the patient isn't crashing? What if their blood pressure is okay, they're awake, but their heart is still racing in AFib?
Then we enter the stable pathway defense. And the immediate goal shifts to rate control. We aren't trying to fix the rhythm right away. We just want to put the brakes on the heart rate so those ventricles have time to actually fill with blood again.
Are we just talking about standard medications here, or are there specific heart rate targets doctors try to hit?
Oh, there are definite targets. For asymptomatic patients, a lenient rate control strategy aims to keep the resting heart rate under 110 beats per minute. But for symptomatic patients, doctors are much stricter, aiming for under 80 beats per minute.
How do they get the rate down?
The first line of defense is usually beta blockers.
How do beta blockers work in this specific scenario?
They target the AV node, which acts as the electrical toll booth between the upper and lower chambers of the heart. By slowing conduction through that toll booth, beta blockers prevent all those chaotic atrial signals from reaching the ventricles.
There are other options too, right? Like calcium channel blockers. But there is a massive flashing neon warning sign in the sources regarding those.
Yes, absolutely. You must strictly avoid a specific class, non-DHP calcium channel blockers, in patients who have heart failure with reduced ejection fraction, or HFrEF.
Meaning the patient already has a physically weak, failing heart muscle.
Right. These specific drugs depress the contractility of the heart. So if you give them to a patient whose pump is already failing, you can completely crash their cardiac output and push them straight into acute heart failure.
Okay, so let's say we've avoided the trap and we've successfully slowed the heart rate down. The patient is completely stable, but we still want to restore that beautiful synchronized rowing team. We want normal sinus rhythm back.
This brings us to the strict rules of timing, famously known as the 48-hour rule for safe cardioversion.
Explain the logic of this 48-hour window.
It goes right back to the stagnant backwater pool. If a patient knows exactly when their palpitations started, and it's been less than 48 hours, medical science has determined there just hasn't been enough time for a robust blood clot to form in the left atrium.
Okay, so it's a safe zone.
Exactly. In that window, it is generally safe to proceed with cardioverting the heart back to a normal rhythm, either using electrical shocks or rhythm-controlling drugs.
But if the AFib has been ongoing for more than 48 hours, or, and this has to be common, if the patient woke up with it and has absolutely no idea when it started, you have to assume there is already a clot hiding in that appendage.
Yes, shocking the heart blind in that scenario is incredibly high risk. So doctors have two options to proceed safely.
Option A is the conservative route, right? You put the patient on heavy blood thinners for at least 3 to 4 weeks, you let the medication dissolve any potential clots over a month, and then you bring them back to safely cardiovert the heart.
Correct. And option B is the fast track. You perform a transesophageal echocardiogram, or T.
T. What does that involve?
Well, the esophagus sits directly behind the left atrium. By sedating the patient and passing an ultrasound probe down their throat, a cardiologist gets a crystal clear, real-time image of the left atrial appendage.
Oh, I see.
If they look inside and confirm there is no clot, they can shock the heart back into rhythm right then and there.
Looking at those two options, why would anyone choose option A? I mean, why wait 4 anxious weeks on blood thinners when option B lets you check for a clot and fix the heart immediately?
It often comes down to clinical logistics and patient tolerance, honestly. A T is an invasive procedure. It requires sedation, specialized ultrasound equipment, and an available echocardiographer.
Right.
A small rural hospital might not have those resources on standby. Furthermore, some patients just cannot tolerate the sedation or the probe. So in many cases, prescribing an oral blood thinner and scheduling a follow-up is the safest, most practical path forward.
That makes total sense. Once we verify it's safe to proceed, how do we actually force the heart back into rhythm? We talked about electricity, the DCCV, but there are drugs and surgeries too, right?
Yes, antiarrhythmic drugs like flecainide or propafenone can chemically reset the rhythm. But they have to be carefully selected based on whether the patient has underlying structural heart damage. Amiodarone is often used if there's structural damage, but it comes with its own risks, like QT prolongation.
And if drugs and external shocks fail.
Then the gold standard procedural intervention is something called pulmonary vein isolation, or PVI.
This goes back to those rogue cells we talked about at the very beginning, right? The automatic focus.
Exactly. An electrophysiologist threads a catheter into the heart and literally burns or freezes a circle of scar tissue around the pulmonary veins. This scar tissue acts like a firewall. It physically blocks those rogue rapid-fire electrical signals from ever reaching the rest of the heart.
Let's zoom out a bit. We've managed the rhythm, or we've controlled the rate. The immediate cardiovascular crisis is handled. But for you, the patient, the biggest long-term fear still looms over the rest of your life. Stroke. How do clinicians build a permanent defense against those clots forming in the backwater pool?
They use a heavily validated stroke risk dashboard. Doctors don't just guess your risk. They calculate it by looking at compounding factors. The CHA2DS2 VASCIC score.
Okay, what does that analyze?
They analyze your age, whether you have high blood pressure, diabetes, previous strokes, or vascular disease. Each compounding issue exponentially increases the likelihood of a clot forming. If your cumulative score crosses a certain threshold, say a 2 or higher oral anticoagulation, meaning blood thinners, becomes mandatory.
And here is a critical distinction in the source material that doctors absolutely cannot afford to mess up. Anticoagulation is divided into 2 distinct buckets based on the type of AFib a patient has. Bucket 1 is valvular AFib. What does that specifically mean?
Valvular AFib specifically means the patient has a mechanical artificial heart valve, or they have moderate to severe damage to their mitral valve, often from childhood rheumatic fever. For these specific patients, the risk of clotting is so uniquely aggressive that there is only one drug choice: warfarin.
And bucket 2 is non-valvular AFib, which covers the vast majority of patients. For them, modern medicine uses DOAC's direct oral anticoagulants. To use an analogy here, DOACs are like the modern set-it-and-forget-it slow cooker of blood thinners.
That's a fun analogy.
Right. You take a standard dose, they have predictable effects in the body, and you don't need constant monitoring.
Whereas warfarin, on the other hand, is like cooking your dinner over a volatile open campfire.
Oh, wow.
It's true. It interacts with your diet, especially leafy greens, and it fluctuates constantly. You have to continuously monitor the temperature of that fire with frequent blood tests to check your INR targets.
And if you don't?
If the fire goes out, your blood clots. If the fire flares up, your blood becomes too thin, and you risk a massive spontaneous hemorrhage.
It's a terrifyingly delicate balance. Now, we have this elegant, incredibly detailed algorithmic system for treating AFib: rate, rhythm, anticoagulation. But there's one massive fatal trap hidden in the diagnostic weeds that every single clinician must avoid. It involves a condition called Wolff-Parkinson-White syndrome.
WPW syndrome. It's a congenital defect where a patient is born with a secret, ungated accessory electrical pathway that connects the upper and lower chambers of the heart.
So it completely bypasses the AV node toll booth we discussed earlier.
Exactly.
Let's explain the extreme danger here. During AFib, the atria are generating 300 plus impulses a minute. Usually, the AV node toll booth blocks most of them, keeping the ventricles safe. But if a doctor sees the fast heart rate, doesn't realize the patient has WPW, and administers AV nodal blockers like beta blockers or calcium channel blockers, what happens?
You block the only regulated pathway. When you close the AV node toll booth, you force all 300 chaotic electrical impulses per minute down that secret ungated accessory pathway directly into the ventricles.
That is like closing the main regulated gated highway to stop a massive fleet of 300 speeding cars, only to accidentally force all 300 cars per minute down a tiny, ungated residential side street. It's guaranteed disaster.
The consequence is immediate. The ventricles cannot handle that speed. They devolve into ventricular fibrillation,
Which means
the main pumping chambers just stop working entirely. The patient goes into sudden cardiac arrest.
one wrong drug choice, and it's a fatal error. This really highlights why managing AFib isn't just about handing out pills, it's about seeing the entire physiological board.
And that includes lifestyle. The source material emphasizes the ESC-SOS integrated care model, treating obstructive sleep apnea, which causes massive overnight stress on the heart, managing weight, strictly controlling blood pressure and blood sugar, adopting a Mediterranean diet. The medication only works if you stabilize the environment the heart is living in.
Everything connects back to the heart. So what does this all mean for you listening? Let's distill the golden rules we've unpacked today. 1. An irregular pulse is AFib until an ECG proves otherwise. 2. If a patient with AFib is actively crashing and unstable, immediate electrical cardioversion is the only answer, life over limb.
3. Never ever shock a stable heart if the AFib has been ongoing for more than 48 hours without checking for clots or doing a month of blood thinners first.
Right. And 4. Modern DOAC blood thinners are the preferred defense against stroke, unless the patient has a mechanical valve or rheumatic valve disease.
5. Beware the WPW trap. Never give AV nodal blockers if that accessory pathway exists.
Understanding AFib means you now have a conceptual map of how a chaotic cellular rebellion can cascade into a systemic, life-threatening crisis, and exactly how clinicians navigate that high-stakes reality.
It's a complex condition, definitely, but with the right algorithmic approach, it's deeply manageable.
But I want to leave you with one final provocative thought to ponder. We noted earlier that permanent AFib is just a clinical agreement to stop fighting for a normal rhythm. You surrender, let the atria quiver, and just use medications to control the heart rate and thin the blood.
Right.
But what actually happens to the physical, microscopic anatomy of those upper chambers decades after we make that decision to just give up? When a heart is left to quiver silently for 20 years, does the tissue eventually adapt to the chaos, or does it slowly, silently reshape itself into something entirely unrecognizable?
That's a profound biological question, and perhaps a mystery for another time.
Absolutely. Thank you for joining us on this deep dive. Until next time.